Hello class, hello nurses. I'm just going to continue with explanations and discussion regarding the assessment of the hematology system. Just a little recap of what we covered Thursday. Please review hemostasis and blood clotting. I gave you those 5 specific stages of blood clotting. Remember, in the second stage, after vessel spasm, we do have platelet aggregation, which begins forming a platelet plug by having platelets clump together. And these need to be activated in order to clump together. And please be aware, I did say that these platelets really do take on a new character when they aggregate and provide that platelet plug. Because as that clumping occurs, they become large semi-solid plugs that are formed in blood vessels and walls to hopefully, become a barrier and disrupt that blood flow. But remember, these platelet plugs are not clots and cannot provide hemostasis. Okay, we're just trying to begin that process of providing hemostasis. And then remember the substances that cause platelets to clump: ADP, calcium, thromboxane, A2, and collagen. Okay. And blood clotting is triggered by the formation of a platelet plug. And remember, these platelet plugs occur from both intrinsic and extrinsic factors. And again, extrinsic is basically substances found in the tissue, and intrinsic is found in the serum, and extrinsic are substances that are found in the tissue. Okay, so be aware of that. And intrinsic factors, those again, problems or substances that are directly in the blood that first make platelets clump and then trigger the blood clotting cascade. Okay, remember I compared it to like a waterfall that kind of transcends down and kind of cascades flowingly. Well, that's exactly what happens within the process of blood clotting or hemostasis. Intrinsic are outside the cell that can also induce platelet plug to form, and they're usually as a result of changes in the blood vessels rather than in the blood. Most common is obviously trauma. Others are inflammation, bacterial toxins, or even foreign proteins. And then that last phase is fibrin clot formation. All right, so hopefully that makes sense to you. Please review that. I'll show you the PowerPoint slide that I really want you not to memorize, but just to kind of look it over and understand how this process occurs. Fibrinogen is a protein made in the liver, and enzymes thrombin remove the end portions of that fibrinogen, converting it into an active fibrin, and then that fibrin mesh formed with clotting factor 13, tightening up that mesh. Okay, and then this is the PowerPoint slide that I really want you to look at. I can't get it all on this, but I want you to see how those intrinsic pathways and extrinsic pathways kind of start forming that common pathway to hopefully have the process of blood clotting occur. But it's just kind of interesting to see all these different factors. And remember, 13 factors are needed to have blood clot. And this is very important to understand because we as nurses so many times give medications that will interfere or delay blood clotting. And that's a very, very important responsibility we have on us. So when we incur that from occurring the way it's naturally supposed to occur, then that makes our patients very much at risk for bleeding. So we have to take these anticoagulants or antithrombin medications or antiplatelet medications that we give our patients very, very seriously, because then, since we are delaying clotting and not having that cascade process or cascade effect occurring, then our patients are very much at risk for bleeding. So we have to watch to see when that first starts occurring, so we can hopefully reverse the medications that we give our patients to prevent them from having a very, very serious bleed. Okay, so hopefully that makes sense. Again, anti-clotting forces, I talked about this the other day, ensures that activated clotting factors are present only in limited amounts, and that makes absolute perfect sense, because we don't want this clotting process to occur all over the body. We want it to be very, very specialized area in the area that obviously had the injury occur. And so it also prevents overenlargement of the fibrin clot, called fibrinolysis, because we don't want an over amount of area to clot, because it would definitely affect blood flow. When patients have a deficiency of any of the proteins for clotting, they're very much at risk for PEMI or a stroke. All right, and we talked about that the other day. And that's just the process of fibrinolysis. Okay. I went over this. I just want you to understand that we're going to see patients as they age have effects, obviously, on their immunity, causing much of a slower response to any type of infection or invasion of an organism that would occur. You're not going to see that real high spike in temperature, indicating that, obviously the body's trying to fight off some kind of pathogen. And remember, the same goes for red blood cells, because that bone marrow starts being replaced with yellow marrow. We don't see a lot of patients. We see most of the patients elderly develop iron deficiency, which means probably the reason their hematocrits and hemoglobins are lower, not significantly lower, is the fact that they just don't eat enough foods that have all those nutrients needed for the process of erythropoiesis to take place. And then, but the one thing you do need to remember is that no matter how old anyone is, platelet count should not change. Everyone should have the adequate amount of platelets in order for blood clotting to take place, and if they don't, then there is some significant reason why they don't. So that's something that a physician or a healthcare provider would have to look into. Okay, so that's that. So and we pretty much went into assessment fairly good. Again, you can read this for yourself as to what kinds of situations or environmental factors, or even their dietary history would have on their hematology system. And obviously, as nurses, assessment is a big part of what we do, looking at the subjective as well as the objective data for our patients. Things that, would make our patients more prone to problems, what kind of chemicals they've been exposed to, any type of cancer that they've had, and what were those treatments for that cancer. Because those particular treatments, especially, chemo and radiation, will affect how your body reacts to future cancer cells, and treatments may make you more prone to future cancer. And thinking about people that have low-grade fever that tends to peak the same time each day, people that have chills, night sweats, they may have viruses, looking at people's energy levels, having more fatigue than usual, or even seeing younger women who have significant changes in their menses. We've talked about skin, pallor, could be regarding red blood cells and circulation, jaundice, purpura, petechiae, hematomas, ecchymosis, and excoriation and pruritus may be a sign of Hodgkin's disease or lymphomas. And then again, anything having to do with the eyes could also alert you to someone having a jaundice, sclera, hemolytic anemia, or even a pale conjunctiva, which would alert you to someone having very, very significant anemia. Even retinal hemorrhages, where they might have a real red flaming color when looked at through an ophthalmoscope. And many times we see this when patients have a problem with thrombocytopenia or a very low number of platelets. And with that retinal hemorrhage due to low platelets, some of these people may also have a poor visual field and lose that because of that particular hemorrhage. Looking in the patient's mouth, pale mucous membranes, mouth ulcers, really could be an indication of low white blood cells or stomatitis, which is usually occurs through neutropenia. Neutropenia is a fancy word for a low number of white blood cells. And really, basically what this is the stomatitis is white exudates on the cheeks that that kind of attack themselves. And that's why many of these patients may need frequent mouth care, things like that. And we'll talk more about these types of things for our patients when we talk about, care of the patient with cancer. Mucosal bleeding, glossitis. Glossitis is a smooth tongue that's very red and shiny and really could indicate that your patient has a vitamin B12 deficiency. Cheilitis is when you've ever seen somebody who have those lesions at the corner of their mouth. And then we look at the lymph system. When we start behind the ears and work down the neck, we check axillary and inguinal areas as well. We look for enlargements or tenderness that aren't normally palpable, and we're concerned about those lymph nodes that if they are palpable, that they usually disappear within 2 weeks after the infection. Enlargements that prolong and occur for 6 weeks or longer, we would definitely instruct that person to have that further investigated. May need something like a biopsy to check for disease or occlusion. Looking at the chest, anybody that has sternal tenderness, tachycardia, tachypnea, usually widening pulse pressures, palpitation of vessels for murmurs or bruits, abdomen, looking for any signs of hemoptymegaly, which really indicates that the liver is enlarged, and sometimes that could be due to the fact that they've had bleeding or may have a liter of blood present in the liver. Splenomegaly, if you can palpate it, that is also not normal, because usually you really can't palpate the spleen under normal conditions. Just be careful if you do assess that and find that there is some enlargement or tenderness in that spleen, which is on the left side, the liver is on the right side, that you don't press too hard, because it can really make your patient very nauseous. Blood in emesis or stools, coffee ground. Coffee ground indicates that the blood's coming in contact with hydrochloric acid. The darker the stool with blood, the higher the bleed. And then think about our patients who have arthralgia or joint pain or bone pain. Could be that they have leukemia, and then we'll talk about all the signs and symptoms of that. All right, so that's just kind of a little recap of the assessment of our patients who have possible hematological problems, looking at dietary problems, and then definitely family history and genetic risk. And what is your patient's current health problem? Is there any lymph node swelling, excessive bleeding or bruising, excessive menstrual flow for women, shortness of breath on exertion, palpitations, frequent infections, weight loss, headache, or paresthesia? And again, that the single most common symptom of anemia is, of course, fatigue. Okay, and these are all that physical assessment that I just talked about. All right. Just again, I went over these in class the other day. Please know what all those mean. And again, when we're talking about the hematological system, thinking about the involvement of the blood cells, red, white platelets, the bone marrow, the spleen, and the lymph system. and thinking about what are some of the crucial functions of these organs and cells, and we know what they are. We've just been discussing them. So let's also, sorry, I went too fast on the slides. I apologize. Let's go over these terms and look at the CBC and determine what all those lab values mean with that test, and how do we as nurses interpret that information. All right, with our CBC, we know CBC stands for complete blood count. We know RBC is red blood count, or red blood cells. WBCs is white blood cells. Hemoglobin, hematocrit. Our hemoglobin measures the capacity of the hemoglobin to carry gases. Usually the average range for a woman in a normal range for hemoglobin is 12 to 16, and for men it is anywhere from 14 to 18. Okay. And remember too that it is the hemoglobin in the red blood cell that carries the O2. And remember when we talked about all the different nutrients and substances needed for the production of red blood cells, iron is needed in order for the O2 to bind to that hemoglobin. Okay, and then we have hematocrit, which is measures packed cell volume of red blood cells expressed as a percent of the total blood volume. Women anywhere from 38 to 47, and males anywhere from 40 to 54. Okay. Usually hematocrit will be 3 times the value of a hemoglobin. So for instance, if your hemoglobin is 33 or 11, your hematocrit will be around 33. Okay. And obviously men's hemoglobin and hematocrit are much higher than women's because men obviously do not menstruate. And then think about when we interpret these numbers, a hemoglobin of 7 or less and a hematocrit of 21 is probably the criteria where the healthcare provider may want to order blood for you. Hematocrit greater than 60% can be very caustic to the body, and we're going to talk about conditions that unfortunately have that occurring. Okay, and I think it's really important to look at hemoglobin and hematocrit and not only know when you see those values on your patient to know that they're abnormal, but what's the cause of them. Okay, because it can be due to bleeding, it can be due to other more serious things, and we know that if we do suspect that our patient is bleeding, we're always watching that H&H, and a lot of physicians have their own specific criteria as to when it's necessary to give our patients blood. Usually with one transfusion, we could pretty much see the hemoglobin raise about 2 points. So if, for instance, your patient had a 7 hemoglobin and they gave them 1 unit of packed cells, we would probably see anywhere from an 8.5 to a 9 hemoglobin rise after that packed cells have been infused. If your patients lose blood very quickly, we'll see the patient become very, very symptomatic, where you'll see things like increased heart rate, decreased blood pressure. But if the patient is losing their blood very slowly, maybe due to a gastritis or maybe has some type of ulcer where the blood loss is very slow but very constant, the patient initially may not have such a great display of symptoms and be quite asymptomatic. And you know, you got to think about the difference between acute blood loss versus chronic blood loss. Remember, we have about 5 to 6 liters of blood circulating in our body, and acute blood loss may not be reflected immediately in the CBC due to fluids and cell parts of the blood which are the same concentration. A lot of times if there is some type of internal bleeding, the hemoglobin and hematocrit may not drop for the first 10 hours, so you're not going to see anything significant on the CBC. CBC lags about 24 hours behind what is actually happening. So, for instance, if your patient went to the cath lab and got back on a Tuesday afternoon and maybe started developing a retroperitoneal hematoma and had a significant bleed, we might not see till the following afternoon, if we drew a CBC on that patient, how significantly that hemoglobin has dropped. But that's why it's important to constantly assess your patient, because you must use signs and symptoms to detect problems before you actually have to wait and see what that H&H is. And so it's important to know that in your syllabus there is a little chart that kind of talks about if your patients lose 10%, 20%, 30%, 40%, or 50% of their circulating volume, what are you going to see manifest in your patient? So I'm not going to get into that, but I would really recommend that you go over that in your syllabus, okay? And a lot of times, you know, depending on how much blood a person has lost and what kind of symptoms we're seeing will determine what the treatment for that patient would be. Do we just need to give meds? Do we need to infuse blood? Or do they just need some nutritional counseling? So look at those particular findings in your syllabus, okay? Because when our patients have chronic blood loss, they might be losing up to, 3 to 5 milliliters a day. After they, eat and increase their activities, they will have tachycardia. Sometimes people have dyspnea on exertion, or other times they might develop orthostatic hypotension. Their heart rates may go up, but their blood pressures can drop. So, like I said, please read over those to kind of see the difference and see what kind of manifestations your patients would display if they lose a particular percentage of their blood volume. Okay? All right, moving on. When we talk about MCV, and this one right here should be MCV, not MVC. It stands for mean corpuscular volume, and what that refers to is just looking at the size of the cell, okay? And that's why we kind of use those terms with our hematology system as either megablastic or macrocytic, which indicates that it's a large but immature cell, or you might refer that cell to being microcytic, which would indicate iron deficiency. So that's what MCV stands for, mean corpuscular volume, okay? Looking at the size of the cell. And then we move down to MCH, which refers to mean corpuscular hemoglobin. And this refers to the amount of hemoglobin in each cell, and therefore its ability to carry oxygen. And remember, there are 4 molecular hemoglobin chains in each red blood cell derived from your iron content. And remember, as we talked about nutrition, eggs are one of the best sources of iron. And then MCHC is mean corpuscular hemoglobin concentration, and that's the percentage of each cell occupied by hemoglobin, about 80 to 90%. Without it, you have iron deficiency or accelerated hemolysis, and that thus causes you to have a decrease in O2. And then I think you know what reticulocyte count is. Reticulocyte count, we talked about that. Remember, those are the immature red blood cells. We see about 1 to 2% normally circulating in the blood volume. When we see a drastic increase, that would indicate that your patient is bleeding. Then we have platelets, and we've talked about those. Not really true cells, but more so much like fragments. But obviously they pose a very, very important function. They help with the clotting process. All right, and then the next one is TIBC, which stands for total iron binding capacity. And what this refers to is looking at whether or not you have too much or too little iron in your blood, okay? And then because iron will move through the blood attached to a protein called transferrin, all right? So your transferrin levels will also be done in addition to a TIBC. And this is a main protein in the blood that binds to iron that, like I said before, transports it through the body, all right? And then the next one is iron. And we look at the amount of iron in one's body. And usually the normal range is about 60 to 170 micrograms per deciliter. And with total iron binding capacity, the normal range for that blood test is 240 to 450 micrograms per deciliter. And then we look at the transferrin saturation, anywhere from 20 to 50%. And many times when we suspect that our patient has some kind of problem with hemoglobin or hematocrit, the physician will order all three of these tests: ferritin level, total iron binding capacity level, on an iron level, okay? And as I said before, the way iron moves through the blood is by the attachment to that protein called transferrin. And when we see total iron binding capacity results very high, it means that body stores are low and a person may have what we call iron deficiency. If they have a low total iron binding capacity, it means that red blood cells are being destroyed too quickly. And we might see it in pernicious anemia. Maybe they have vitamin B12 deficiencies due to the fact that they don't have that intrinsic factor in their stomach, or also we might see it in sickle cell disease. So that's what those mean, okay? And then the next one, I've already talked about ferritin level. So let's talk about hemoglobin electrophoresis. And all this is the different types of hemoglobin in the blood. Many times what they'll do is they'll take a blood sample and then put it in like a centrifuge, and they kind of spin it out, and they look at the different types of hemoglobin chains that are in the blood, and those can indicate certain abnormal hemoglobin chains. And for instance, with sickle cell, which I know we're not going to talk about because you'll get this in pediatrics, if they have the S chain, that would be indicative of sickle cell. There's also hemoglobin F, hemoglobin A, and so that is what we're trying to look at when they do this hemoglobin electrophoresis. And then a leukocyte alkaline phosphatase is a stain that they do, and with neutrophils, there is a particular enzyme that's produced by normal neutrophils, and the leukocyte alkaline phosphatase would be increased during episodes of infection and stress. But if you see a elevated neutrophils count without an increase in your LAP or your leukocyte alkaline phosphatase, this is very much associated with chronic cyclogenous leukemia. So that would give us another indication that possibly your patient would have that. Okay, and then we have the Coombs test, indirect and direct. And the direct Coombs is used to detect antibodies that are stuck to the surface of the red blood cell. And sometimes these antibodies can sometimes destroy red blood cells and cause anemia. And indirect is the Coombs test that looks for free-flowing antibodies against certain red blood cells, they would do an indirect Coombs test if you had a reaction to a blood transfusion, okay? Because normally there would be no clumping, but if there's because there would be no antibodies to those red blood cells, okay? But many times when we see a patient have a reaction, they would definitely run this test, okay? So that's basically some of the other terms or the other lab diagnostic studies that would be done by the physician to definitely determine what the patient's cause of certain overproduction of cells or underproduction of certain cells. Gives us a little bit more information about the patient, okay? And again, hemoglobin, hematocrit, red blood cells, white blood cells. We talked about the 5 different types of white blood cells just the other day, namely referred to as the differential. And then these are other tests measuring bleeding and coagulation. All right. All right, and these are some other tests that measure bleeding and coagulation. As I said, prothrombin time. We pretty much replaced the PT with an INR, especially when our patients are on Coumadin. The international normalized ratio. And then, of course, a PTT, partial thromboplastin time, which is a test we use to measure the bleeding time when our patients are on heparin. And then anti-factor XA. If you go back to that chart that had the actual breakdown of intrinsic and extrinsic factors in regards to the clotting process or hemostasis, we did see factor XA. They look for the anti-factor XA with patients being on things like Xarelto or apixaban or even Lovenox. And then there are studies that show platelet aggregation. There's other ones too, such as capillary fragility, because they look at how easily capillaries are damaged, because maybe the patient has increased petechiae, and they're looking at capillary fragility rather than poor platelet function. And they can actually do what we call a bleeding test, which looks at vascular and platelet activity during hemostasis. The normal time for that is 1 to 9 minutes. And then in regards to other types of studies that you may see done, maybe a serum folic acid level on your patients. I already talked about serum iron, because if we see less than normal values, it could determine iron deficiency. If your serum iron levels are high, it could determine hemolysis of those red blood cells. And then we look at vitamin B12 assay, decrease with inadequate absorption, because that measures the body's ability to absorb vitamin B12. We've already talked about reticulocyte count. Bend-Jones protein, we're going to talk a little bit more about that with multiple myeloma, but it is a large protein that should not be present in the urine. It looks at multiple myeloma, which is a plasma cell cancer, and patients may also have hypercalcemia and a predisposition to kidney stones, because their calcium levels are so high. So those are just to name a few of the other types of testing that may be done on your patient. And then as far as imaging on your patients, there may be some radioisotopic imaging that evaluates bone marrow's ability to activate cell formation and sites of iron storage. And then for radioactive colloids, it may be a test to look at organ size, liver and spleen function, and then of course standard x-rays. One of the manifestations or characteristics of multiple myeloma is bone destruction, in which patients can see like a Swiss cheese appearance. And remember, these isotopes they used help to evaluate the bone marrow, looking at that actual way in which they actively produce cells, and as I said before, for iron storage sites. And there's something else I just kind of wanted to touch upon about iron overload. You know, we're measuring iron levels on our patients, and some of the signs of maybe too much iron, which can happen, is chronic fatigue, joint pain, and abdominal pain. So these are some of the initial signs and symptoms of someone who maybe has too much iron in their bodies. Okay? So the last thing on assessment that I'm going to discuss is bone marrow aspiration and biopsy. And what this is about is maybe not really having all the answers. So the next thing we need to do is actually get a piece of the inside of that bone marrow before, you know, cells are actually emitted out into circulation. And what this will hopefully do is provide a lot of information about the bone marrow and the kinds of cells that they are producing. It is an invasive procedure, so it's very necessary that we have a signed consent and the patient's very well aware of what is actually going to happen. This can be very scary for patients because now we're not really sure what's going on, and this test can really give us the final answers of what we want to know about what exactly is causing the patient's problems. We used to do these a lot at the bedside. It can be done at the bedside, but it can also be done in an exam room or laboratory. And the important thing is to explain to the patient what we're actually going to be doing, because it can be fairly painful if the physician does not provide the patient with proper local anesthesia. Okay, and there's also a time when we're actually seeing the physician get the specimen that the patient really needs to hold very still. Okay, so let's just kind of talk about this for a few minutes and then get a kind of a good idea of what exactly is happening when this patient has a bone marrow biopsy. One of the most common sites we use for a bone marrow aspiration is the iliac crest, but a physician can also use the sternum if it's necessary. Okay. When we're doing a bone marrow aspiration, really we're looking for stem cells, okay? And we know those are used, for the production of any type of cells that the body needs. The healthcare provider may be at this time really suspecting aplastic anemia, leukemia, or even some kind of thrombocytopenia type problem. And what we're doing, as I said before, is looking at these cells before they actually get released out into the serum. And we're looking at the cells to determine any abnormality, and usually it can be done by a hematologist, an oncologist, or an internal medicine man. Really not a very big risk for bleeding infection if it's done under strict sterile conditions. After aspiration, bone cells will regenerate within 1 week. So we don't really need a whole lot of material from the bone marrow. Really, they're only taking about 3 to 5 mLs of marrow. Okay. So the first thing you're going to do is obviously explain the procedure to the patient. let them know that you're going to be there, and then give them an opportunity to ask the physician if there's any questions they have. The first thing we want to do is provide that local anesthesia and make sure that it has taken effect before we actually, use the materials or the equipment to press down and kind of turn it to get a piece of that bone marrow out. After the area is anesthetized with lidocaine and it's prepped, the physician, like I said, really kind of makes a sterile field. He'll have on a sterile gown, obviously sterile gloves, and once that area has been anesthetized and it has taken effect and it's fairly numb for the patient, all they'll do is use what we call is a trocher, and it's kind of like, it kind of looks like something you would use, like, how when you have a little thing that you're making like a cutout for a cookie, maybe at Christmas time. It's kind of the same principle where you kind of put it around the area of where the bone marrow is, and the patient will lay on their side. The nurse is facing the patient near the head, and obviously her main role is for support and comfort, and they use this trocar, and it's pushed in and then it kind of twists into the bone, and you'll hear like a pop when it actually enters into the bone marrow, and there's like a vacuum state, and they just kind of pull out or aspirate 3 to 5 mLs of marrow with the needle. And after aspiration, they'll put pressure on the site, and the vacuum created will seal it off. The area may be sore for a few days, about 3 to 4 days, but there should be absolutely no hematological compromise with this test. The results for a kid will be in about 2 days, or about 1 day, I'm sorry, and then for adults it'll be about 2 to 3 days. So that's basically all it is. And I think the worst part of it is the waiting. The patient then waits for the results to come back. There's really no other significant nursing care that you need to provide for it. Sometimes just apply a pressure after it's done, and the follow-up care is you just want to prevent any excessive bleeding, cover the site with a dressing, and watch for bleeding and infection. Might just give someone a mild analgesic, no aspirin, maybe an ice pack to the area, and avoid contact sports for 48 hours. Provide emotional support to the patient and the family when waiting the results. Remember, this is a strict procedure, so infection could happen. So you want to explain to the patient if he goes home to just look, or have somebody look at the site, or the patient look at the site and make sure there's no swelling or redness or drainage from that site. And that's really about all in regards just waiting around for the results to happen. So that's really about it. The thing that we'll learn in a little bit when we get to stem cell transplant is when they're going to harvest bone marrow for a stem cell transplant, they do it basically in about the same way, but instead of doing it at the bedside, those patients will definitely be taken to surgery, because we're going to be taking a lot more for a bone marrow harvest. About 400 to 800 milliliters of bone marrow is harvested. Okay, and instead of using lidocaine, they'll definitely use some type of Versed or sedation to put the patient out. But basically you're doing the same thing, but obviously taking more of the contents of the bone marrow out. So that's about it for assessment. So this concludes this, and I'm going to begin on some of the hematological problems. Thank you so much for your attention, and if you have any questions, please let me know. Enjoy your evening.